Good evening, everyone. Today we will talk, inshallah, about minimally change glomerulonephritis. We finished the introduction to glomerulonephritis in three parts. Part one included approach, history, clinical picture, investigation, and renal biopsy. Part two included different clinical presentations, and part three included the treatment and management. Then we will start to go more deeper and discuss each etiology for glomerulonephritis. And today we will start by minimally change glomerulonephritis. This is our agenda. This slide includes the most important notes that you should know about minimal change. The most important one. What you should know about minimal change, it is the most common type of nephrotic. It is the most common type of nephrotic in children, counting about 80% of cases. 80% of cases of nephrotic syndrome in children is caused by minimal change. And while in adult, minimal change accounts for 10 to 20% of cases. It is the most common cause of nephrotic in children and accounts for 10 to 20% of cases in adult type. What about the pathology? Under light microscopy, the glomeruli appear normal. This is the second most important note. It appears normal. From where it accounts its name, it's minimally change. Under light microscopy, there is no change. The glomeruli appear normal. While under electron microscopy, there is food process effacement. We will see it later. يبقى الباثولوجي under light microscopy glomeruli appear normal, while under electron microscopy there is food process effacement. The third note that you should know that there is minimal change characterized by a high rate of remission after steroid treatment. The highest rate of remission after steroid. It has also a better long-term renal outcome, and it is characterized by its earlier onset. أنا على طول بقول للطلبة يعني كل نوع من الجلوميرونيفرايتس بنحب نحط نوع أو اسم كده جنبه من البداية قبل ما نيجي أتكلم عنه مور ديب، يعني يلخص الموضوع تفضل فاكره. المينيمال تشينج بنقول على طول ان هو من انواع الحلو، يعني بقول لهم كده اكتبوا كده جنب العنوان حلو كويس. ليه؟ لانه characterized by better long term outcome. الاوتكم بتاعه كويس. characterized by اكتر واحد بيستجيب للاستيرويد، ده من الكرايتيريا بتاعته في معظم الحالات highest rate of remission after steroid treatment. تمام؟ فما ننساش المعلومات دي. السلايد دي very important، فيها اهم او the most important notes about المينيمال تشينج. كل حاجه اهم حاجه انك تعرف ان هو الموست كومن كوز اوف نيفروتيك في التشيلدرن، ان هو في الباثولوجي بيابير نورمال في اللايت مايكروسكوبي، وان هو كاركتر ان هو very good response to steroids. Now let's talk about the epidemiology. Under the age of 6 years, below 6 years, minimal change accounts for 94% of cases. يبقى it is near 100% of cases below 6 years of age. Mostly any patient or any child presented by nephrotic syndrome, he is minimally changed. Or any child below 6 years of age is presented by nephrotic syndrome is minimally changed until proved otherwise. Between the age of 8 and 16 years, minimal change accounts for 50% of cases of nephrotic syndrome. يبقى 50% from nephrotic syndrome cases are caused by minimal change, while In younger age, it accounts for 94%. Incidence ranges from 1.2 to 7 per 100,000 cases. Cases of nephrotic syndrome increases during winter. There is variability among different population. Like in United Kingdom, the incidence is low, nearly 1 per million, while it is high in United States, nearly from 27 per million. Also, it is common in South Asians and Native Americans, but rare in, this is an important note, much rarer in African Americans. What is more common in African Americans is focal segmental. Focal segmental is highest in African Americans, we'll talk it later, while minimal change is rare in African Americans. Type, what about sex? Minimal change during childhood is more common in boys, while in adolescent, minimal change equally affect male and female. During childhood, it is more common in boys, while in adolescents, it affects both equally. Type, what about prevalence? Prevalence, as we talk, below the age of 15 years, it is more common, accounts for 78% of cases. 78% of cases. With increasing age, incidence decrease. Incidence of minimal change decrease from 78 to, in young adults, while white or black, it accounts from 15 to 23%. While in middle age and old age, while either white or black, it accounts from 16 to 21%, a range of 15 to 20% of cases of nephrotic syndrome. يبقى أقل من 15 سنة المينيمم تشينج accounts for حوالي 78%. في اليونج أدلت بيتراوح من 15 ل 20، وفي الأدلت برضه بيتراوح من 16 ل 20% من التوتال حالات النفروتيك سيندروم. طيب, each one from glomerular diseases either is caused either as a primary or idiopathic or secondary to other conditions. And you should know it. You should know the secondary causes for each one of them. It's very important in your clinical life to exclude a secondary cause, because if it is a secondary minimal change or a secondary focal segmental or a secondary membranous, treatment is treatment of the cause. If it is due to drug, stop the drug. Due to infection, treat the infection. If it is due to malignancy, we should cure malignancy. For secondary causes, the treatment is treatment of the cause. While primary causes, treatment is different from each one of them, either supportive or we need immunosuppressive drugs. The most important secondary causes for minimal change is drugs, and the most important one is non-steroidal anti-inflammatory drugs. It can happen after interferon alpha, it can happen after gold and lithium, but it's much more rare. The most common drug to cause minimal change is non-steroidal anti-inflammatory drug. Also, minimal change can happen as after in allergic patients, as an allergy after pollens, or allergy to house dust, or insect stings, or after immunization, after poisoning. يبقى the second one is allergy or atopy. Also, one of the most important causes for minimal change is malignancy, and the most important one is Hodgkin disease. This is very important slide in our clinical practice and also in exams. Very important. Secondary causes for each glomerular disease, you should know it by heart. Secondary causes, if I ask you what are the secondary causes for minimal change, you should tell me. Non-steroidal anti-inflammatory drugs, Hodgkin disease, and allergy or atopy. Now let's talk in more details about these secondary causes. In non-steroidal anti-inflammatory drugs causing secondary minimal change, it is usually happens as an idiosyncratic reaction to NSAID. It usually followed chronic use of NSAID, not acute use. Type. What is peculiar to that secondary minimal change caused by NSAID? Is it similar to, is it a classic presentation of minimal change? No. It is characterized by, massive nephrotic syndrome, heavy proteinuria, and severe hypoalbuminemia, also characterized by, usually associated with impaired renal function and renal biopsy. Also with the features of minimal change, there is also acute interstitial nephritis and T-cell infiltration. Let's revise. In NSAID causing secondary minimal change, it is usually an idiosyncratic reaction, usually follows a chronic NSAID use, not acute use, and have some peculiar presentations. This nephrotic syndrome is usually massive, not mild, usually associated with impaired renal function, and in renal biopsy there is an associated acute interstitial nephritis. This is what about NSAID. What about Hodgkin disease? Minimal change is the most common type of nephrotic syndrome in patients with Hodgkin disease. This is an important note. Type. What is the pathogenesis? What is the pathogenesis? What happens in Hodgkin patients causing minimal change? It is proposed that a protein called c-MAF-inducing protein is overexpressed in red Sternberg cells and in podocytes. Causing this protein will cause decreased phosphorylation of nephrin. Nephrin is a protein that's present in the slit diaphragm. This decreased phosphorylation of nephrin will lead to cytoskeleton rearrangement and proteinuria. يبقى هيحصل abnormality في السلات diaphragm. ده المصفى اللي بتبقى موجوده في الجلوميرولس اللي بتمنع الباسج اوف بروتين. ده الصفايه، البروتينز ماسكه في بعض، وهنشوف الصوره دلوقتي ماسكه في بعض وبتمنع الباسج اوف بروتين. لما يحصل فيهم مشكله هتبدا بقى يحصل بقى ان هم يبعدوا عن بعض ويحصل ليكج اوف بروتين. ده اللي بيحصل. يبقى السي ماف inducing بروتين ده will cause decreased phosphorylation و affection of nephrin causing proteinuria. طيب. Also, relapses of minimal change usually follow exposure to bee sting and foods. And a very important note, very, very, very important, that minimal change relapses usually follow respiratory tract infections, especially upper respiratory tract infections. A very important note and very important in our clinical practice, and we will discuss it later. And we tell patients that if they are on steroids or on treatment and they had upper respiratory tract infection, we tell them to increase the dose of steroid, because we know that, and we'll discuss it more in details, usually there is a relapse after that upper respiratory tract infection. Now let's talk about the pathogenesis. Let's talk about the pathogens. On the left side, there is the picture. It's the normal podocyte and normal condition. And on the right side, what happened in minimally change disease. In the normal side, let's focus here about the nephrin. Nephrin, one of the important proteins in the slit diaphragm. This is called slit diaphragm protein. It is the barrier that prevents the passage of more proteins. Nephrin, this P is phosphorylation, needs phosphorylation to be more active, needs phosphorylation. When it becomes phosphorylated, becomes more active, and it will help in the structure of the cytoskeleton. Look here, the cytoskeleton of the podocyte. Very important. Cytoskeleton formed by the alpha-actinin, F-actin, والsynaptobudine. When the nephrin is phosphorylated, it will help in the cytoskeleton in the podocytes. What happened in minimally change? And look here, what is the other mechanism that prevent the passage of proteins to pass from inside the glomerulus in the Bowman's space and lost in urine? This is the glomerular basement membrane. These structures, look here, is the anionic sites, molecules with the anionic charge that repel albumin with a negative charge to pass through from here, from this fenestrine. Albumin with a negative charge come here, found this negative charge, and then it go back. These are the two mechanisms in the normal condition. What happened in minimally change? The two most important markers that is suggested to play a role in minimally change, markers are CD, which is the most important one, CD80, and the second one is angiopoietin-like 4. You can be asked about them. What are the most important markers or the most studied markers in minimally change? CD80 and angiopoietin-like 4. What happened? It suggested that microbial products and interleukins interact with the toll-like receptors 3 and 4, leading to overexpression of CD80. This overexpression or increased level or high levels of CD80 will lead to decreased phosphorylation of nephrin. No phosphorylation to nephrin. When there is no phosphorylation to nephrin, this will lead to no help to the cytoskeleton. Look here, the cytoskeleton. And compare it to the left side. Cytoskeleton here is adequate. Here is inadequate due to decreased phosphorylation of nephrin. This is the proposed mechanism or the suggested mechanism of how CD80 can affect cytoskeleton arrangement and nephrin, causing minimal change. What about an angiopoietin-like 4? The suggested mechanism of angiopoietin-like 4 causing minimal change is that it decreased the anionic sites. Look here in the glomerular basement membrane. What are the numbers of the anionic sites having anionic charge to repel albumin compared to the normal side? In the normal side, there is a lot of anionic sites. Here, angiopoietin-like 4 causes this decreased number of the anionic sites, allowing albumin to pass through the glomerular basement membrane. This is how CD80 and angiopoietin-like 4 usually cause minimal change. Let's go more focus about the role of microbial products in the pathogenesis. We prescribed in the previous slide that microbial products can cause overexpression by its interaction with the toll-like receptors, causing overexpression of CD80. What is very attractive here that 70%, take care of that number, 70% of minimally changed patients with relapse, 70% of patients who relapses documented what? Respiratory infections. We have said it before. 70% from patients who relapse documented respiratory tract infection. So, microbes, viral or bacterial, have a role in minimal change. What happened? What we described before, that microbial products from gram-negative bacteria or viral particles like toll-like ligands usually interact or bind to, as we described, toll-like receptors 3 and 4 on podocytes, causing more expression of CD80, which will lead to decreased phosphorylation of nephrin and causing proteinuria. And we also discussed the second mechanism about loss of the anionic charge. Loss of the anionic charge in glomerular basement membrane usually caused by the angiopoietin-like 4. This is a suggested pathogenesis, that there is loss of proteins which carry negative charge in the glomerular capillary wall are lost, leading to disruption of the charge barrier and allowing albumin to pass through. Heparin sulfate proteoglycan, which is the most important or the most major source of the anionic site in the glomerular basement membrane, are reported to be low or normal. Heparin sulfate proteoglycan, one of the main anionic site in the GBM, reported to be low or normal in the glomerular basement membrane of minimal change patients, while studies don't confirm. There is still a debate about that mechanism in the pathogenesis of minimal change, but it is a suggested theory. A third theory is about the podocyte dysfunction, which is now a much more accepted theory for minimally change disease, that there is alteration of the slit diaphragm proteins, and the most important we discuss it is there is the reduced nephrin phosphorylation, and there is alteration in integrin mediated podocyte adhesion, and the most important one causing that is CD80 and angiopoietin-like 4. CD80, and it is the most studied one in minimal change, is a co-stimulatory molecule that's present in antigen-presenting cell, and it's found to be expressed on podocyte in children with minimal change disease. The studies found that serum from patients with minimal change disease who are in relapse induces CD80 expression in cultured podocytes, but not serum from patients in remission. يعني ان السيرم اللي اتاخد من البيشنت اللي كانوا في ريلابس ده انديوس CD80 اكسبريشن في البودوسايت، ده معناه ان كان تركيزها عالي. انما في السيرم اللي اتاخد من بيشنت اللي كانوا في ريميشن ما عملش انديوسنج الاكسبريشن اكتر. طيب ايه تاني اللي بيقول ان ممكن CD80 يعتبر ماركر او ممكن نستخدمه انه ممكن يبقى افكتد او عالي او ليه رول في المينيمال تشينج؟ ان هو الهاير ليفلز can be found in patients with in urine in children with steroid sensitive minimal change، وان الليفلز دي اليورينري ليفلز دي decrease to normal with remission. يعني with treatment لما تعالجوا من المينيمال تشينج او دخلوا في ريميشن الليفلز بتاعت CD80 decreased. طيب هل هو ده very specific او pathognomonic او characteristic للمينيمال تشينج بس؟ لا، CD80 ده لقوا ان هو expressed in other glomerular diseases كمان، ولكن اليورينري ليفلز بتاعته كانت هايست فين؟ في المينيمال تشينج عن اللي لقوها في الاذر جلوميريولار ديزيز. كان الهايست ليفلز موجوده في المينيمال تشينج. طيب الباثولوجي، let's talk about the pathology. اللايت microscopy. First one is light microscopy. It's characterized from its name, it is minimal. There is minimal affection or minimal abnormality present in light microscopy. Light microscopy هيبان normal glomeruli. ده الكاركترستيك بتاعه. But there might be mild changes can be found. Mild changes that can be found. Like increase in mesangial, slight increase in mesangial matrix. Some hypercellularity can be found in some patients. Very small number of patients, around 10% of glomeruli, can show some degree of sclerosis. Fat and hyaline droplets can be found in proximal convolute tubules. But never to forget that the most important that in minimal change by light microscopy, glomeruli appear normal. Right. What about the immune fluorescence? By immune fluorescence, immunoglobulin will complement rarely found. يبقى second important that the minimal, there is still a minimal affection by immune fluorescence. Deposits, immunoglobulin and the complement deposit rarely found in minimal change. If present غالبا بيبقوا limited للميزانجيوم. Some patients can show IgM deposits, and some clinicians, some nephrologists يعني prefer أو they think that it might be IgM nephropathy وغالبا بيبقى ده بيبقوا poor clinical outcome، بيبقى more severe nephrotic presentation وبيبقى poor prognosis. IgM nephropathy is usually a bad prognostic condition. Prognosis is much more worse than minimal change. يبقى غالبا response to steroids is little or less than minimal change. Also in some patients might show C1q deposits and في الغالب ده ممكن يكون C1q nephropathy في بعض الحالات، ولكن أهم شيء إن أنت ما تنساش إن classic minimal change بيبقى الimmunoglobulin والcomplement rarely found. يبقى في اللايت microscopy normal, immune fluorescence في الغالب no deposits، إنما في الإلكترون مايكروسكوبي هو ده الموست important إنه في الغالب هيكون في إيه؟ بودوسايت food process effacement. food process effacement or fusion. والجلوميرولار بيسمنت ممبرين هيكون نورمال. المشكله كلها بتكون في البودوسايتس، وبيكون في no electron dense deposits، مفيش deposits في المينيمال تشينج. Let's look here. This is the podocyte، دي البودوسايت، ودي الفود processes. There is food process effacement مش موجودة. هنا الافكشن food process effacement or fusion. طيب. What about clinical manifestations? Never to forget that minimal change usually is presented or most commonly presented by nephrotic syndrome. Nephrotic syndrome is what we discussed in introduction: heavy proteinuria, hypoalbuminemia, leading to generalized edema or anasalca. There is some dyslipidemia, and usually mild renal impairment or no renal impairment. So, biologic, the most important sign is edema, is the first sign, and the most one patient usually presented by, usually present by weight gain. Edema is usually bilateral, pitting edema of rapid onset, usually start by periorbital edema. Usually at its earlier stages it's mild, and then it increases to be a severe edema causing anasarca and pleural effusion and ascites. Bowel edema in some patients can lead to a diarrhea. Macroscopic hematuria, usually it is not seen in minimal change unless it is complicated by renal vein thrombosis. Take care, macroscopic is usually not seen. If a patient with minimal change presented or complain of a macroscopic hematuria, you should exclude renal vein thrombosis. Some patients may develop what is called white nails, Merck line, and we discussed in introduction. And some in adults, usually in adults, may develop xanthomas and xanthelasma. In patient with minimal change, usually the blood pressure is normal. Some patients can complain of hypertension, and during relapse, this is usually due to as a reaction from hypovolemia and hypoperfusion, leading to increased renal levels and activating RAS system. And it might be an iatrogenic secondary to the use of steroids, CNIs, in treatment of minimal change. Abdominal pain and nausea. Abdominal pain and nausea can happen and are common manifestations in minimal change disease. Pain is usually a dull pain caused by massive ascites and bowel hypoperfusion and edema. But if patients or if the child complain of severe pain, should respect it, and you should suspect of peritonitis and acute pancreatitis. Very important. If the child still complain of a more severe pain, you should exclude peritonitis or acute pancreatitis. Investigations. We describe it in introduction also. This is a revision. We discussed that there is heavy proteinuria and hypoalbuminemia and dyslipidemia in children, and you should know these definitions and these numbers. In children, nephrotic range proteinuria is defined as proteinuria more than 50 mg per kg per day, 50 mg per kg per day, or more than 40 mg per hour per square meter. In children is nephrotic. This is a question. ده سؤال هتتسأله، ازاي بنعرف البروتينوريا او النيفروتيك رينج بروتينوريا في الchildren. بنعرفها it is more than 50 mg per kg per day or 40 milligram per hour per square meter, or 200 milligram protein per millimole of urine creatinine, or protein to creatinine ratio more than 3 milligram per milligram. ده في التشيلدرن. طيب في الادolescent والادلت بنقول nephrotic range proteinuria is defined when proteinuria is more than 3.5 gram per day. 3.5 gram per day. طيب. غالبا احنا بنستخدم اليورينري بروتين تو كرياتينين ريشيو لانها بتكوريليت مودريتلي مع البروتينوريا اللي بتبقى collected في 24 اور urinary proteins. ما ننساش، ده معلومة مهمة جدا، ان في المينيمال تشينج البروتينوريا مش بس بتكون ماسيف ولكن بتكون ايه؟ selective proteinuria، بتكون mainly composed of albumin. اليورين may show hyaline cast and fat bodies and can show microscopic, take care of micro not macro, microscopic hematuria can happen in 20% of patients. عشان بعضكم بيعتقد انه ما بيحصلش مايكروسكوبيك هيماتوريا، لا، بنشوف بيبقى فيه مايكروسكوبيك هيماتوريا في 20% من المينيمال تشينج patients. Hypoalbuminemia and usual albumin is less than 2.5 gram per deciliter. There is also hyperlipidemia, and as we described in the introduction in details, and what are the causes and what is the management. It is usually composed of increased cholesterol, elevated total cholesterol, and the LDL cholesterol. This is a universal feature in nephrotic syndrome. If there is massive proteinuria, there is also can be accompanied by elevated triglyceride and VLDL. Renal functions is usually normal, but might elevate usually due to hypoperfusion and hypovolemia, usually aggravated by the use of diuretics. There might be mild hyponatremia, and usually it is a pseudo hyponatremia as a result of severe hyperlipidemia. There also might be elevated hemoglobin and hematocrit levels and thrombocytosis, usually in patients with minimal change as a result of volume contraction, and decrease in intravascular volume. Also, we discuss it in introduction that the total serum calcium and vitamin D levels may be low. Total levels, total calcium and vitamin D due to hypoalbuminemia and decreased protein-bounded calcium. But ionized calcium is usually normal and no treatment is indicated. There is a little affection of that decrease in total calcium and vitamin D on the clinical condition. But what is important in clinical practice is that minimal change children usually have an increased risk of infection, as all patients with nephrotic syndrome, but this condition is much more higher. This risk is much more higher in minimal change patients. There is increased risk for infection, mainly sepsis, peritonitis, cellulitis, and pneumonia. Usually due to a lower serum levels of immunoglobulin G and urinary loss of factor B and propertin. Serum complement or C3 levels are elevated in minimal change disease. Streptococcus pneumoniae, Haemophilus influenza, other encapsulated bacteria are the most common cause of peritonitis. Peritonitis is rare in adults, but it's much more common in children. Varicella can cause a severe form, can be a severe condition, usually in patients receiving immunosuppression, and take care from the hypercoagulable states we described in more details in introduction. What about diagnosis and differential diagnosis? To remind you that minimal change is the most common type of nephrotic in children, so never to forget that renal biopsy is not routinely done in children younger than 10 years of age. We tell you that almost in less than 10 years of age, if any child presented by nephrotic syndrome, it is a minimal change until proved otherwise. However, if there are, take care of that, if there are features that are not characteristic for minimal change, when there is some doubt that this nephrotic syndrome might not be due to minimal change, renal biopsy is done. Like what? If there is hypertension, if there is red cell cost, if there is gross hematuria, if there is renal dysfunction, all of these features are not characteristic for minimal change. So I doubt. I became suspicious that this nephrotic syndrome might be not due to minimal change. So I should perform renal biopsy in these conditions. Also, if there is no response after a 4 to 6 weeks course of steroids, I should perform a renal biopsy because this is not classic for minimal change. These steroid-resistant cases might be due to focal segmental or represent a hereditary form of nephrotic syndrome. In adults, scenario is different. In adults, minimal change represent only 10 to 20% of cases. So in adults, usually that's presented by nephrotic syndrome, a renal biopsy is required to establish our diagnosis. This is not clear like in children. As we told you that minimal change patients who are steroid dependent or steroid resistant usually are or represent a form of focal segmental glomerulosclerosis in subsequent renal biopsies. Is very important that patients with minimal change, early diagnosis of minimal change who became steroid resistant or steroid dependent, if there is a subsequent, in many cases of them, with subsequent renal biopsies, they usually show features of focal segmental glomerulosclerosis. Now let's talk about the natural history of the disease. Natural history of the disease. The next two slides are very important definitions in our management for minimal change. Very important, and should know that definitions. Very important. It will help us during the management to tell patients there, and you should know it, there is complete remission or partial remission or steroid dependent or steroid resistant. Very important to know these definitions. The definition with for nephrotic syndrome, we discussed it before. Complete remission. What is when the patient is defined as to having a complete remission? The definition is different from children to adult. In children, complete remission is defined as when urinary protein to creatinine ratio is less than 200 milligram per gram. Less than 200 milligram per gram or less than 1 plus protein on urine dipstick, on ordinary urine dipstick for 3 consecutive days. Again, when to define a child with a complete remission, either by to define a child to have a complete remission either to have a urinary protein to creatinine ratio less than 200 milligram per gram, or no protein on urinary dipstick for 3 consecutive days. This is for the children. What about adults? Adults are defined to have a complete remission when proteinuria is less than 0.2 gram per day. Less than 0.2 gram per day or less than 200 milligram per day, and serum albumin more than 3.5. This is for complete remission. What about a partial remission? Partial remission, to have a protein reduction 50% or more, reduction of proteinuria 50% or more from the presenting value, and the absolute urinary protein to creatinine ratio is between 200 milligram to 2000 or 2 gram per gram. This is for children. Again, يبقى I have two conditions. عندي شرطين، ان يكون حصل decrease او reduction في البروتينوريا اكتر من 50%، يعني نزلت اكتر من النص، بمعنى ان الشايلد ده كان مثلا جاي ببروتينوريا مثلا 3.5، دلوقتي بقت 3.5 جرام، بقت 1 جرام، يبقى حصل ريدكشن اكتر من 50% من الفاليو اللي هو كان جاي بيها. هو كان جايب 3.5، نزلت ل1، يبقى نزل اكتر من 50%. ده الشرط الاولاني. الشرط الثاني ان تكون البروتينوريا دي بتوين 200 مللي جرام و 2000 مللي جرام، تكون بتوين 200 مللي جرام و 2000 مللي جرام. ليه؟ لان هو لو اقل، احنا لسه قايلينها اهي، قايلينها فوق، لو اقل من 200 مللي جرام يبقى ده كومبليت ريميشن. طب لو هو اكتر من 200 مللي جرام، اكتر من 200 لغايه 2000، يبقى ده بارشال ريميشن. ده الكلام ده فين؟ في التشيلدرن. طيب في الادلتس امتى اقول عليه ان ده بارشال؟ زي ما احنا ما قلنا فوق، في الكومبليت ريميشن في الادلت قلنا يكون less than 0.2 جرام او اقل من 200 مللي جرام. طيب امتى اقول عليه بارشال؟ لو ازيد بقى، لو اكتر من 200 مللي جرام او ازيد من 0.2 جرام لغايه up to 3.5 جرام، ويكون حصل ريدكشن في البروتينوريا برضو اكتر من 50%. يبقى البارشال ريميشن لازم يكون حصل ريدكشن في البروتينوريا more than 50% من البيز لاين، من اللي هو جاي بيها، هو جاي برقم معين ينزل اكتر من النص، وان البروتينوريا تكون ما بين 200 مللي جرام و2 جرام. ده البارشال ريميشن. طيب النو ريميشن اللي هو ما محققش الشروط اللي احنا لسه قايلينها للريميشن فوق في الاثنين، ان هو ما يكونش حصل failure to reduce البروتين or failure of reduction of proteinuria by at least 50% من البيز لاين، ما نزلتش اكتر من 50% من البيز لاين، وان يكون البروتينوريا حاليا الابسوليوت فاليو بتاعتها اكتر من 2 جرام. يبقى ان هو failure to achieve these targets، يبقى ساعتها اقدر اقول عليه ان هو no remission. طيب very important السلايد دي بقى عشان في المانجمنت and to follow up our patients. طيب الريسبوندر to treatment، initial responder يعني ده استجاب في البداية، يبقى ده who had or attained complete remission within the initial 4 weeks، يبقى complete remission within 4 weeks of steroid therapy. This is initial responder. طيب initial non-responder or steroid resistant, when I define my patient as steroid resistant. Failure failure of complete remission to achieve complete remission after very important definitions after 8 weeks of steroid therapy. This is in children. يبقى when I define the children as steroid resistant after 8 weeks of steroid therapy if they don't achieve complete remission type. In adults, when I define the adult as steroid resistant or non-responders after 16 weeks. Very important definitions. Very important in exams and very important in our clinical life. In adults I should wait. ما تستعجلش. الادلت مش زي الchildren. الchildren انت ليه بقول عليهم ان هم بدري؟ انه لو ما استجابش بعد 8 اسابيع بس لانه ده الطبيعي في المينيمال تشينج. الطبيعي في المينيمال انه يستجيب بدري للاستيرويد. في الادلتس الوضع مختلف. فالادلتس بيديلي الريسبونس، ممكن يتاخر. عشان كده ما اقدرش اقول عليه انه ده ريزيستنت او نون ريسبوندر الا بعد 16 اسبوع، بعد 4 شهور. بعد 4 شهور قد ايه؟ من دوز ستيرويد 1 مللي جرام بير كي جي بير داي. يبقى after 16 weeks of prednisone treatment at a dose of 1 milligram per kg per day and no response, then I can define this adult as steroid resistant. A relapse. What is the definition of relapse? A relapse is defined as urinary protein to creatinine ratio more than 2000 milligram per gram or more than 200 milligram per millimole or 3 or more plus of protein on urinary dipstick for 3 consecutive days in children. In children, I can define this child as having a relapse either by urinary protein to creatinine ratio more than 2 gram or in urinary dipstick if there is 3 or more plus protein in urine for 3 consecutive days. In adults, I can define this adult as having a relapse if I found proteinuria more than 3.5 gram per day that occurred after complete remission for more than 1 month. These relapses can be infrequent or frequent. يعني الريلابس دي بتحصل قليل ولا كتير؟ طيب ادي مهم بقى القصة دي. infrequent relapses او infrequent relapser لو كان حصل within the 6 بتختلف بقى لو انا في خلال ال6 شهور او في خلال 12 months. في خلال ال6 شهور او في خلال ال12 months بيختلف في ايه؟ انه والله الانفريكوينت ده infrequent relapse لو حصل just one relapse within 6 months of initial response، يعني بعد ما حصل initial response في خلال next 6 months لو حصل just one relapse, this is infrequent relapse. أو or في next 12 months after initial response حصل 1 to 3 relapses within 12 months, this is infrequent relapse. By logic, what is frequent relapse? Frequent relapse 2 or more relapses within 6 months of initial response or 4 or more relapses in 12 months period. يبقى ال infrequent relapse لو حصل just one relapse في خلال 6 شهور ده infrequent relapse. لو حصل من 1 ل 3 ريلابس في خلال 12 شهر ده infrequent relapse. طب الفريكوينت ريلابس لا اكتر. لو في خلال ال6 شهور حصل 2 او اكتر في خلال 6 شهور ده frequent. لو حصل 4 او اكتر في خلال 12 months ده frequent relapse. طيب the last definition is steroid dependence. When I define my patient as steroid dependent, if there is 2 consecutive relapses during if there is 2 relapses during steroid treatment or within 14 days of completing the steroid treatment, this is steroid dependence. يبقى if there is 2 relapses 2 consecutive relapses during أثناء التريتمنت من الاسترويد أو في خلال 14 days بعد ما خلصت الاسترويد يبقى ساعتها ده ستيرويد ديبندنت. يعني مش مجرد ان هو لازم اثناء الاستيرويد حصل ريلابس، لا، لو في خلال اسبوعين بعد ما خلصت الاستيرويد ده ستيرويد ديبندنس. Very important definitions, very important 2 slides. Without steroid treatment, spontaneous remission is very low. The steroid treatment is usually effective in inducing remission, but relapses are very common. Among the children, 20% never relapse, 20% relapse infrequently, and 50% have numerous relapses. Very important to know these figures. 20% never relapse, 20% relapse infrequently, and 50% have numerous relapse. And these 50% are classified as frequent relapsers and steroid dependent. مهم جدا ان احنا نكونوا عارفين الناتشرال هيستوري ده. very important عشان ده اللي حضرتك هتقوله انت على طول. ده مهم في ايه؟ البروجنوزس. الام والاب هيسالوك والله يا دكتور هل ابني هيخف؟ طب نسبة حدوث ده قد ايه؟ طب لازم الارقام دي تكون عارفها عشان دي اللي هترد بيها على الاب والام. والله ان 25% ان شاء الله لو مش هيحصل اي انتكاسات، 25% ممكن تحصل بعض الانتكاسات يعني من 1 ل3 في السنة او اقل، وفي 50% بيحصل انتكاسات متكررة، وبعض الحالات ممكن هيفضل على الكورتيزون لفترات طويلة. دي الردود اللي انت هترد بيها على الاب والام. لازم تكون عارف الارقام دي وترد عليها يعني evidence based. طيب. There is no support for the concept that ان هو الديزيز بيحصل له will resolve during puberty، عشان كان بعض الناس ان هو والله عقبال ما يبقى يوصل على البلوغ او في البيوبرتي ان هو المرض هيخف تماما. لا، مفيش حاجة تسبورت ده. ولكن ان هو unusual to see children with minimal change انهم بيحصل لهم relapses during child. ان المعظم ان في معظم الحالات ان شاء الله الريلابسز بتخف وبتقل جدا. however ده اللي احنا بنأكد عليه ان هو ان في الغالب البيشنتس اللي بيفضلوا في remission more than 5 years are less likely to relapse. يعني غالبا لو قعد فترة أكتر من 5 سنين في remission مفيش أي انتكاسات إن شاء الله بيبقى نسبة تعرضه للانتكاسات قليلة جدا. المعلومة اللي احنا قلناها كذا مرة وبنأكد عليها تاني ودي very important إن 2/3 أو حوالي 70% من الريلابسز، 70% من الريلابسز بتحصل during upper and or lower respiratory tract infection. وبالتالي الكلام ده احنا بنبقى منبهينه وبننسست على الانفورميشن دي للاب والام للطفل، ان انت تخلي بالك كويس جدا ان اول ما يحصل upper او lower respiratory tract infection، اي عدوى في الصدر او اي كحه او في صعوبه في نفسك، ان انت تخلي بالك ممكن تحصل انتكاس. وبالتالي اللي بيحصل ان احنا لو لقينا ان احنا ادينا شورت كورس 5 days من البريدنيزولون، او عملنا ايه؟ زودنا الجرعه بتاعت البريدنيزولون لمده 5 ايام شورت كورس كده، ده مع بداية الانفكشن ده بيقلل نسبة حدوث الريلابس، بيديكريز الريت اوف ريلابس from around 60% to around 30%. ان انا بقلل الريسك انه ممكن يحصل ريلابس من 60% ل 30%. ده فيري امبورتنت المعلومة دي، وبتفرق جدا في التعامل مع المريض. اللونج تيرم رينال فانكشن في الغالب بتبقى نورمال unless طبعا لو كان حصل لا قدر الله رينال فين ثرومبوزس، ده بيأثر جدا مع في البروجنوزس للمريض. وزي ما قلنا ان في الغالب اللونج تيرم رينال فانكشن بتكون كويسه، ده على عكس الاذر جلوميرولار ديزيزز، وده بيبقى كاركترستيك للمينيمال تشينج انه في الغالب ان شاء الله بيكون very good long term prognosis. طيب التريتمنت، نبتدي بقى ندخل فور التريتمنت. هنتكلم في الاول على general considerations اللي احنا قلناها في الانترودكشن في البريفيوس بارت، ان احنا غالبا هنشتغل على ان احنا هنادفايس بلو صوديوم دايت عشان تكنترول الاديمه. البيد ريست should be avoided عشان ما نزودش الريسك فور ثرومبوزس. الدايركتس في الغالب infrequently used في التشيلدرن، ولكن لان غالبا severe volume depletion، ولكن الدايركتس في الغالب بنستخدمها في الادلتس اكتر. Very important to give thrombosis prophylaxis, especially if the serum albumin is less than 2.5 milligram per deciliter. والستاتينز are rarely used غالبا في especially في الchildren لأن بيكون في rapid response للستيرويدز. التريتمنت ده موجود from الكيديجو جايد لاينز، هنتكلم عليه واحدة واحدة. هنبتدي بالأول بالchildren تريتمنت بالchildren، وهنتكلم جزء جزء. هنتكلم اول حاجه على الانيشيال ابيسود. هنتكلم هنتريت ازاي. recommendations from الكيديجو، ان احنا recommendation ان احنا طبعا الستيرويد ثيرابي هنبتدي طبعا بالستيرويد ثيرابي بريدنيزون اور بريدنيزولون should be given for at least 12 weeks. يبقى الستيرويدز for at least ايه في الاندكشن او في الانيشيال ابيسود 12 weeks. level of evidence 1B very strong evidence. طيب هنبتدي بيها ازاي الستيرويدز؟ سنجل ديلي، هنبتدي بديلي سنجل ديلي دوز تيك كير، يبقى كل يوم ديلي سنجل دوز at a starting dose of 60 mg per square meter per day or 2 mg per kg per day with a maximum dose of 60 mg per day. يبقى I will start by steroids for at least 12 weeks single daily dose. طيب هنكمل ازاي؟ الديلي دوز دي daily dose should be continued for at least 4 to 6 weeks. 4 to 6 weeks even if the patient showed complete remission very early. I should continue this daily steroid dose for at least 4 to 6 weeks, followed by alternate day dose. If I start by daily dose, then for 4 to 6 weeks, then I shift to alternate daily dose, alternate day medication يعني يوم أو يوم لأ at a single dose of هننزل بقى بالجرعة 40 ملغ per square meter or 1.5 ملغ per kg. هننزل بالجرعة هنا احنا قلنا 60 ملغ and 2 ملغ per kg per day. هنا 40 ملغ or 1.5 ملغ per kg with a maximum dose of 40 ملغ on alternate days. For how long? For 2 to 5 months. يبقى هنستارت by daily steroids for 4 to 6 weeks, followed by alternate day steroids for 2 to 5 months with tapering of the dose. ده في الانيشال episode. طيب how I treat infrequent patient with infrequent relapses. Children with infrequent relapses. I should treat them with a single daily dose of prednisone. يعني الملخص ان احنا هنعيد اللي احنا اديناه في الانيشال ابيسود، هنعيد تاني الاندكشن. هندي daily daily هنشتغل daily steroids with the same doses اللي هي كانت 60 ملغ per square meter or 2 ملغ per kg maximum 60 ملغ per day, same doses for induction daily until the child is in complete remission with definitions اللي احنا قلنا عليه. complete remission for at least 3 days. يبقى if a child presented with a relapse, I should treat him with the same regimen for induction, daily steroids 60 mg per square meter or 2 mg per kg until the child became in complete remission for at least 3 days. And then after achieving the complete remission, the child should continue his daily dose, single dose after achieving complete remission. هيحصل shifting، هنحول ل alternate day medication بعد ما عمل complete remission، هنخليه يتحول ل alternate day medication، يعني يشتغل يوم او يوم لا، برضه بالسيم دوزز اللي احنا قلنا عليها قبل كده، بال 40 ملغ بير سكوير متر or 1.5 ملغ بير كي جي، والماكسيموم 40 ملغ on alternate day. for how long بقى؟ for at least 4 weeks. for at least 4 weeks. ده في الريلابسز، في علاج الريلابس اللي هي الانفريكوينت هشتغل زي اللي فاتوا، هبتدي مع الديلي ستيرويدز لغايه لما يدخل في complete remission for at least 3 days، وبعد كده هشفت ل alternate day medications for alternate day steroids for at least 4 weeks. ده for treatment of relapses. طيب to treat بقى frequent relapsers and steroid dependent هعالجهم ازاي؟ السجشن ان احنا نعالجهم with daily steroids، نبتدي برضو معاهم daily steroids، نفس الكلام until the child has been in remission for at least 3 days, followed by alternate day steroids. يبقى نفس الكلام، هديله daily steroids لغايه لما يدخل في complete remission، وبعد كده هشفت لي alternate day steroids for at least قد ايه؟ 3 months. هكونتينيو هنا بقى في الفريكوينت ريلابسر والستيرويد ديبندنت فتره اطول شويه، هكمل هديله ديلي ستيرويدز في البدايه لغايه لما يدخل في كومبليت ريميشن، على الاقل 3 ايام، بعد كده هنعمل شيفت to alternate day steroids for at least 3 months. السجشن برضو ان احنا يفضل ان طبعا alternate day steroids ان to be kept at very lowest possible dose to avoid the side effects of steroids. We can shift from alternate day steroids to daily steroids if the alternate day steroids is not effective. يعني لو انا هو ماشي على يوم ستيرويدز يوم او يوم لا، وفجأة عمال يحصل ريلابس لقينا مش effective، هعمل له شيفتنج ان انا احوله على daily steroids. طيب برضو امتى برضو ممكن استخدم الديلي ستيرويدز؟ لو انا على alternate day steroids، لو انا شغال ستيرويدز يوم او يوم لا ومش جايب ريسبونس، هحوله على ديلي ستيرويدز، هخليه كل يوم. برضو لو هو على alternate day steroids وجاله ودخل فيه respiratory tract infection، هعمل له shifting ل daily steroids زي ما احنا ما قلنا لشورت كورس اوف daily steroids 5 to 7 days عشان اقلل الريسك في الريلابس. طيب الريكومنديشن امتى استخدم when to use other immunosuppressive drugs، الكورتيكوستيرويد sparing agents when to use it في علاج في التشيلدرن اللي هم الفريكوينت ريلابسرز والستيرويد ديبندنت. امتى استخدمهم؟ هستخدمهم very important when they develop steroid related side effects. طيب what are the options to treat? What are the options for these immunosuppressive drugs? First one is alkylating agents. alkylating agents اللي هم مين؟ cyclophosphamide or chlorambucil. دولت اللي احنا ممكن نستخدمهم as corticosteroid sparing agents. هم دولت الريكومنديشن ليهم ايه؟ ان هم اقدر استخدمهم في الفريكوينت relapsers و very strong evidence 1B. very strong في الفريكوينت relapsers I can use الالكيليتنج agents for frequent relapsers، ولكن استخدامهم في الستيرويد dependence is weak. هم they are not preferred for steroid dependent patients. يبقى ال very important note ان الالكيليتنج agents سايكلوسومايد والكلورامبيوسيل بيستخدموا امتى؟ هم بيجيبوا very good response في الفريكوينت relapsers، ولكن they are not preferred في الستيرويد dependent patients. طيب السايكلوسومايد الدوز بتاعته بتكون 2 ملغ بير كي جي بير داي في غالبا for 8 to 12 weeks. 8 to 12 الكورس بتاعهم 3 months with a maximum cumulative dose. ده very important عشان to avoid side effects. الماكسيمم cumulative accepted dose is 168 ملغ بير كي جي. Cyclophosphamide shouldn't be started until the child achieved a remission، يعني ما استخدموش إلا لما يدخل فيه remission. بالنسبة للكلورامبيوسيل دوز is 0.1 to 0.2 ملغ بير كي جي بير داي for ممكن أديه for 8 weeks، والماكسيمم accepted cumulative dose is 11.2 ملغ بير كي جي as an alternative to cyclophosphamide. Very important note that second courses shouldn't be given. Second courses of alkylating agents shouldn't be given. يبقى to know تاني when to use alkylating when to use other immunosuppressives or corticosteroid sparing agents when children develop steroid related adverse effects. Options, the first option is alkylating agents cyclophosphamide or chlorambucil. They are preferred in frequent relapsers. They are not preferred in steroid dependency. The course cyclophosphamide can be used for a course up to 3 months. The chlorambucil can be used up to 8 weeks. Second courses shouldn't be given. Levamisole can be used in frequent relapsers and steroid dependent children at a dose of 2.5 mg per kg on alternate days for at least 12 months. Also, calcineurin inhibitors can be used with a very strong evidence. Cyclosporin can be administered at a dose of 4 to 5 mg per kg per day in 2 divided doses. TAC can be used in a dose of 0.1 mg per kg per day, starting dose divided in 2 divided doses. The duration for CNI administration should be given for at least 12 months. يبقى alkylating agents usually given from between 2 to 3 months. Levamisole with CNI should be given for at least 12 months. MMF can be used, but the evidence is much weaker. Starting dose is 1,200 mg per square meter per day in 2 divided doses for at least also 12 months. Retoxy Map should be considered only in patients with steroid dependency and steroid dependent children who continue to have relapses despite the use of steroids and corticosteroid sparing agents. يبقى when to use rituximab, when you can give rituximab if the child is steroid dependent and still have relapses despite steroids and other immunosuppressive administrations. Mesoribine shouldn't be used, while azathioprine shouldn't be used. Immunization in children should be given to reduce the risk of serious infections. Pneumococcal vaccination should be given. Influenza vaccination should be given annually to children and their household contacts. Live vaccines shouldn't be given until the steroid dose is below 1 milligram per kg per day. Live vaccines are contraindicated in children receiving corticosteroid-sparing agents. Healthy household contacts can be immunized with live vaccines, live attenuated vaccines. Following close contact with varicella infection, we can give in non-immune children on immunosuppressive, we can give them varicella zoster immunoglobulin if available. Steroid resistance. What about treatment of steroid resistant children? When we can define them with as steroid resistant, if no response after 8 weeks of steroid treatment. A recommendation that the initial therapy for these patients for steroid resistant children is CNI, and they should be continued for at least 6 months, and then stopped if no response, and if there is a response, they should be continued for at least 12 months, accompanied by a low dose of steroids. Also, ACE and ARB or ARBs should be used during treatment. Children who will not with steroid resistance who fail to achieve remission by CNI, we can use with them MMF or high dose steroids or combination between MMF and steroids. Cyclophosphamide shouldn't be given in steroid resistant children. Very important. يبقى cyclophosphamide is preferred to be used in children with frequent relapses, but not preferred in patients in children with steroid resistant or steroid dependent. If a child having a relapse, they should be treated with either oral steroids and return to the previous successful regimen before. This is an algorithm describing the history and treatment of children. If in a child with a biopsy proven or suspected minimal change, we should start steroid therapy. Usually, they will respond in 95% of cases. 25% will never relapse after that. 25% have infrequent relapses, and 50% will have frequent relapser, and they will continue as a frequent relapser or steroid dependent. In frequent relapsers, we can use CNI or cyclophosphamide. In steroid dependent, we can use CNI. In frequent relapsers, we can use either of them. If they enter remission, okay. If they still relapsing, I can use cyclosporin or tacrolimus. If they still relapsing on CNI, I can use MMF or Retoxy Map. If the children are treated with CNI and have side effects of CNI, you can use the MMF or Retoxy Map. If they still relapse, I should repeat a biopsy. Non-responders or steroid-resistant children, the options are CNI. If they develop toxicity or side effects, I can use MMF or high-dose steroids, and I continue symptomatic therapy, and I can repeat the biopsy. What about treatment of adults? Treatment of adult will continue with the same consequence. We'll start by, in the initial episode, we should treatment with either prednisone or prednisolone as daily dose of 1 milligram per kg, maximum 80 milligram, or I can start by alternate day steroids at a single dose of 2 milligram per kg, maximum of 120 milligram. Usually, most of us usually start by single daily steroids. Type duration. What about the duration? If the patient shows a remission or if complete remission, I should continue for at least 4 weeks, and for a maximum of 16 weeks if complete remission is not achieved. يبقى هستart by steroids either by daily or alternate day steroid. هكونتينيو for لو البيشنت حصل complete remission هكونتينيو for at least 4 weeks. طب ما دخلش في complete remission هكونتينيو for 16 weeks. مهم جدا عشان تعرف انت هتكمل مع المريض بتاعك لمدة قد ايه. طيب البيشنتس اللي هم دخلوا في remission we should taper the steroids slowly over a period of 6 months after achieving remission. يبقى ابتدي اكمل الستيرويدز وابتدي اسحبها بالتدريج على فترة 6 شهور. Patients with contraindication or intolerance to high dose steroid, I can use oral cyclophosphamide or CNIs زي ما described في frequent relapsers. والبيشنتس اللي هم حصل لهم relapse I should treat them with the same regimen زي ما ابتديت فيهم في الاندكشن او في الانيشيال ابيسود. يبقى البيشنت اللي عندهم كونترا انديكيشن او انتولرنس للهايدوز ستيرويدز زي الانكنترول دايابيتس او عندهم سايكاتريك كونديشنز او سيفير اوستيوبروسيس I can use CNI او oral cyclophosphamide. البيشنتس بقى اللي هم الفريكوينت ريلابسرز والستيرويد ديبندنت ايه الاوبشنز اللي عندنا؟ I can use oral cyclophosphamide for 8 weeks or CNIs either cyclosporin 3 to 5 mg per kg per day in 2 divided doses or tacrolimus 0.05 to 0.1 mg per kg per day in 2 divided doses for 1 to 2 years. For 1 to 2 years. Either في الفريكوينت relapse او الستيرويد ديبندنت اللي هم حصل لهم ريلابس على السايكلوفوسفاميد او اللي هم مش عاوزين يستخدموا السايكلوفوسفاميد. احنا قلنا السايكلوفوسفاميد خلي بالك انت انه بيعمل جونادال توكسيستي سبيشالي مع الكيوميلاتيف دوز الكبيره، فلازم تدسكس. مش مع كل الحالات طبعا هيحصل معاها جونادال توكسيستي، بس انت لازم تتناقش مع المريض او المريضه بتوعك وبتفهمهم انه والله لا في ريسك، انت من حقه ان انت لازم تقول له، ده حق المريض. والله حتى لو انت هو لو لقى مع انك انت قلت له والله ان الريسك لو احنا ادينا بدوز صغيره وان الكيوميلاتيف دوز قليله اللي احنا هنديها بتاعه السايكلوسومايد وان الريسك اوف جونادال توكسيستي قليله، والله هو اقتنع وهياخد ماشي. ما اقتنعش وقال لك لا انا مش عاوز وخلاص ده حقه، يبقى انت ساعتها هتستخدم السي ان اي. او ان انت ممكن تستخدم الاوبشنز بتاعتك في الفريكوينت ريلابس ستيرويد ديبند الام ام اف هتدي من 500 to 1 جرام twice daily for 1 to 2 years للبيشنتس اللي هم intolerant للستيرويد السايكلوسومايد والسي ام اي. الناس اللي هي كورتيكوستيرويد ريزيستنت وما فيش اي ريسبونس، في الغالب ان انت هتعيد تقييم البيشنت وتشوف ان ده هل ده مينيمال تشينج ولا ده اذر كوزز من المينيمال تشينج، وان زي ما قلنا انه ممكن يطلع مثلا اي جي ام، ممكن يطلع سي 1 كيو، يعني في اذر كوزز. طيب زي ما قلنا الالجوريزم في الادلت بقى هنا ان هم ده غالبا، ده بيبقى غالبا قلنا لازم هنعمل بايوبسي عشان نشوف ان ده مينيمال تشينج. هنبتدي الاستيرويد ثيرابي، الديوريشن بتاعتنا من 4 to 6 ويكس، 4 ويكس لو حصل كومبليت ريميشن، ولو ما حصلش بنكمل ل 16 ويكس. دخل في ريميشن كان بها والله ممكن بعد كده يبقى ستيرويد ديبندنت، ساعتها هنستخدم السي ان اي. infrequent relapsers اللي هو بيحصل له ريلابس كل شويه، لما بيحصل الريلابس هنتريت الريلابس زي الانيشيال ريجيمن. الفريكوينت ريلابسرز اللي هم ممكن هنديهم ساعتها سايكلوفوسفاميد او سي ان اي ونشوف الريسبونس بتاعهم. انما لو هو من البدايه كان عنده كونترا انديكيشن للستيرويد، ساعتها هنبتدي معاه السي ان اي، ودخل في ريميشن ماشي، ما دخلش في ريميشن او دخل في سايد افكتس من السي ان اي، ساعتها ممكن ان احنا نتريد باي الام ام اف والريتوكسي ماب. السمري بتاعنا احنا خلصنا كده المينيمال تشينج من الكومبريهنسيف، وجبنا التريتمنت من الكيديجو جايد لاينز. هنتكلم عن السمري بقى، هناخده من اوكسفورد. اوكسفورد بيجيب لنا السمري يعني ايه سريعا كده وتو ذا بوينت. ما ننساش ان ده المينيمال تشينج بيكون less common في الادلت، بيمثل 10 او 15 to 20% من الكيس في حالات النفروتيك في الادلت، ولكن بيمثل more than 90% من الكيس اوف نفروتيك في التشيلدرن. ما ننساش ان المينيمال تشينج بيكون excellent prognosis. ان الاتيولوجي هو ممكن يكون idiopathic او secondary مين الموست كومن non steroidal anti inflammatory drugs، الهيماتولوجيكال مالجنسيز، الهودجكن ديزيز، وما ننساش الاتوبي في 30% والالرجي. الكلينيكال بيكتشر احنا عارفينها خلاص، ده نيفروتيك سيندروم بيشنت جاي، وقلنا الانفستيجيشنز عارفينها خلاص. الهيستولوجي ما ننساش انه في الباثولوجي في اللايت ميكروسكوب بيكون نورمال، الاميون فلوريسنس بيكون نيجاتيف، والالكترون مايكروسكوب هيكون فيه ديفيوز افيسمنت. التريتمنت ما ننساش الاهم شيء ان احنا عارفين انه هيستجيب، واكتر جي ان هيستجيب للستيرويدز. غالبا هنبتدي يعني احنا خلاص اخدنا التريتمنت بالتفصيل، مش هنتكلم في الدوزز تاني. ان بيحصل عرفنا خلاص ان ممكن يعني الريلابسز very common to happen، وعرفنا ان في الفريكوينت ريلابسرز والستيرويد ديبندنت والستيرويد ريزيستنت، وعرفنا ازاي تو تريت في التشيلدرن والادلت. واهم حاجه ما ننساش ان انت في الغالب ان احنا في التشيلدرن وفي الادلت ان انت هتبتدي بالستيرويدز، ولو ما حصلش ريسبونس للستيرويدز في الغالب الاوبشن اللي وراه هيكون السي ان اي. السي ان اي بينفعوا في الفريكوينت ريلابسرز والستيرويد ديبندنت والستيرويد ريزيستنت. وما تنساش ان السايكلوفوسفاميد بيبقوا بريفيرد في الفريكوينت ريلابسرز، ولكن النتائج بتاعتهم او نوت بريفيرد غالبا في الستيرويد ديبندنت او في يعني في التشيلدرن بالذات. طبعا احنا السورس بتاعتنا comprehensive والاوكسفورد والكيديجو guidelines. Thank you. وإن شاء الله the next video will be we'll talk about the focal segmental glomerulosclerosis. Thank you.